MAGIC is an online survey which was sent to breast cancer specialists throughout Europe and other countries in the world. And MAGIC stands for Multidisciplinary Application of Genomics in Clinical Practice. Together with other colleagues, I participated at this online survey, which questioned our feelings regarding the Multigene assays that have a predictive and prognostic value to give adjuvant chemotherapy in women with an estrogen receptor positive, HER2 negative breast cancer. Together with this questioning on when do we give adjuvant chemotherapy, the survey was also looking to the application, the use, and the not use of these multigene assays throughout different countries. There were about 900 respondents, so physicians, that responded to the survey, and they invited people for a roundtable discussion from countries with more than 30 physicians replying to this survey. What we did find was quite astonishing, that the indication to give adjuvant chemotherapy in these women with an estrogen receptor positive, HER2 negative breast cancer was very different across the different countries. We tried to look into which criteria each specific physician, whether it was a surgeon or a gynecologist or a medical oncologist or even a pathologist, which criteria are used today to give a patient with such a breast cancer chemotherapy, going from patient demographics like age, performance status, to tumor characteristics like the tumor size, the grade, the lymph node status, the estrogen receptor expression, the quantitative receptor expression, the progesterone receptor, proliferation markers from the clinic like Ki67. And we established some sort of a flow chart to see which factors, which criteria are common between the countries. And we did see quite a lot of differences on which base that physicians throughout Europe decide on when to give chemotherapy in these patients. Regarding the application or the use of the non-use of these multigene assays for prognosis and for predictive reasons to give chemotherapy, about 55% of the respondents already use these tools to decide on giving chemotherapy or not giving chemotherapy. Those that don't use these, they told us that 2/3 of these physicians were happy to use these if they were available. So the majority of the respondents already use these tools for prognostic and or predictive reasons. Another result that came out of this survey was that the non-use of the tools was mainly because of the not being available, the high price, so it's very expensive, the not being reimbursed by the health authorities, as being the three main important reasons for not having these tools. And another result that came out of the survey was that those physicians already using these tools were more likely to look into international guidelines like the ASCO guidelines or the St-Gallen guidelines or the NCCN guidelines. It were especially those physicians already using these guidelines that were using the tools in the clinic in daily practice. What was also clear was that the tool is more likely to be used in node-negative breast cancer patients than in node-positive breast cancer patients. Mainly, it's important for the health authorities to see that by using these tools, that chemotherapy may be less likely being used in the patients. Because 2/3 of these patients, where we now believe there is a high risk, have a low risk by doing these multigene assays, especially in the patients with lymph node negative breast cancer, and especially in these centers across the world where a lot of chemotherapy is given. They may benefit from these tools by lowering the number of patients who are giving chemotherapy. It will be a cost-benefit exercise, as we have seen in countries that are already using these tools, like Ireland, now also in the UK, the Netherlands, Greece. Some countries in Europe don't use these tools, like in Sweden. Like in Belgium, we don't use these tools very much because they're not reimbursed. So we have to lobby with the health authorities.